Okay, thank you and welcome everybody. And of course, first, thank you, Martina, for this opportunity to present our care trajectory or the change we have made in our care trajectory in this project. My name is Hanneke. Many of you I know already, but well, I'm going to present this together with my colleague Suzanne. Suzanne, can you do the next slide? Yes, so as Martina already said, we work in the UMCG, that's a medical center in the north of Groningen. As you can see, this is a map of the Netherlands, and we're up in the northern. In our hospital, of at least you can see the UMC is the blue one. It's one of the university medical centers. We have 8 of them in the Netherlands, and we're the only hospital in the region that provides complex care and complicated diagnostics and treatment for patients with rare diseases. And cancer care, together with healthy aging, is and transplantation, is one of the focuses of our hospital. Well, but just in quite a lot of places, similar places in the world, the population is also aging in the Netherlands. And in the northern of the Netherlands, we have even more older inhabitants than in the other parts of the Netherlands. So taking care of elderly patients and specific elderly cancer patients is quite daily practice for us. And we have many patients of them in our hospital. So that's a little bit about the region we're working in. To give you an idea, I guess the most of you, except Martine and perhaps Sophie, haven't been in the Netherlands yet, but before. But I hope we can meet each other after the COVID pandemic again in the Netherlands. Next slide, please.
Maybe it's good to add that for us it's good if it's interactive, right? If someone has a question, they can just ask. Hanneke?
Yeah. And Sophie, you're always welcome. Well, the immediate reason we started changing this our care trajectory had to do with our colleague. She's a surgical oncologist, and she had operated an 80-year-old man with a tumor in his rectum. And afterwards, after surgery, he developed major complications. He became delirious, he weakened, he had a pneumonia, and he was going to die. And when she spoke to his brother, it became apparent that the patient was already actually doing very little before surgery. He was just sitting at home in his chair and occasionally walked around his garden. He had quite a small garden. And well, he was, as we know now, vulnerable on multiple domains. And he was talking to his brother, and his brother was wondered if he had known that this was a possible outcome, and even the fact that he could decline. If this patient had known this, he wouldn't undergo surgery. And the question then at that moment she had was whether surgery was the best appropriate treatment for this patient. The balance between under and over treatment is always very difficult, and I think most of you know this figure I have in the slide, the benefits of cancer treatment, but also the harms of cancer treatment. And of course, surgery is one of the big modalities, treatment modalities of surgery, but well, it can do very well, but it can also harm patients and give functional decline. So that was one of the reasons to start this, and she started to talk with colleagues about it and also with the nurses. And it appeared, well, this information about his functioning and the frailty was already inventoried by the nurse at the outpatient clinic. However, this information was not structurally discussed with the doctors in a treatment discussion. But it was only noted by the nurse in the electronic patient file, but it was not available for the surgeons. So this very relevant patient-specific information was not shared. And also the specific information about the frailty and the possible related risk of complications and functional decline neither. And I think this is very important. So she talked it over with nurses, and we, I mean a few enthusiastic healthcare professionals among Suzanne and also her colleague. We start to change the care trajectory. Next slide, please. So in this care trajectory, normally, so the current or the previous care trajectory, if a patient enters the outpatient clinic for a suspected malignancy, the doctor talks to the patients, gives them some physical exams, and after that, he or she will discuss the possible treatment options. And sometimes the patient, if necessary, gets additional diagnostics. And then the patient is discussed in the multidisciplinary tumor board. All our cancer patients are discussed in the multidisciplinary tumor board. And then afterwards, the outcome of this and the treatment plan will be discussed with the patient, and then we start the treatment. So we needed to change this trajectory, and we needed to add points of view to our multidisciplinary treatment board. And next slide, please. And central in this change was the understanding of the patient from a geriatric point of view. Getting to know the patients besides the treatment options, but also the goals and the preferences of the patients, but also to gain more insight in the general health status of the patients from a geriatric point of view. And therefore we needed to change the care trajectory. Next slide, please. So what we changed is, and in this change, nurses have quite an important role. What we've changed is that the nurses at the outpatient clinic go and sit with the patient and the relatives often and talk to the patient. And they have a semi-structured interview about what is important to the patient. So they collect a lot of information about the patient preferences, the patient's goals, what they think, what is of value for the patient, but they also screen the patient for vulnerabilities. And this information is not longer left only in the electronic patient record, but it's also shared in the MDT, the multidisciplinary treatment board. And I think that's the most important change also. So the nurse has now an important place in the discussion about the treatment, and she shares her knowledge about the patients in that discussion. And also we have a geriatrician now being present. And previous there wasn't a geriatrician. We only had she wasn't there. This was just a surgeon, the radiotherapist, and oncologist, and that was it. So the nurses have a permanent place, and at the start of that, we needed to train the nurses because the knowledge about geriatric, of course, was not sufficient. So we trained the nurses to increase their knowledge and also to perform a geriatric, or at least a short geriatric assessment, and to gain insight in the patient's goals and preferences. Next slide, please. And often we get the question, so why do you involve nurses, and why don't you just refer every patient to the geriatrician? Well, Suzanne is going to show why we don't do that. But I think nurses have a lot of knowledge that is quite broadly focusing on such things as functioning in daily life, the dependency of people. They are very accessible to patients. Patients tell nurses much more, at least in the Netherlands. And patients tell a lot about their functioning, but also about their fears to the nurses, and they don't tell them to the doctors. I always tell about how they act when they're sitting with the doctor, with the surgeon. They're always putting up their nice clothes and sitting right, um, sitting up. And at the moment when they're with the nurses, the jacket goes off and the buttons get untied, and they're sitting much more relaxed. And they started to talk about their fears and what's important to them. But also nurses have often much more time than surgeons to talk with patients. And in that way, they can collect a lot of information, which is relevant for patients' well-being, but also for possible treatment outcomes and getting insight in what is important to a patient. Also, nurses have not a competitional position towards doctors. They have their own discipline, and doctors are used to work with nurses, and they're not being seen as a threat to their profession. So at least in the Netherlands, nurses can point out specific things about the patient towards doctors. So I think that's also very important. And nurses are, or yeah, well, can represent the patients very well. They can really explain very well in the tumor board discussions about what is relevant for the patient. So they're some kind of an advocate for the patients. So I think that's really the added value of nurses to this process. And we often hear things, aspects of patients from, for example, about their cognitive functioning from the family or from the patient himself. That wasn't seen by the doctor yet. And also about first signs of mental problems, for example. So I think that are all important aspects for the treatment, and that is why nurses have an important role in it. Next slide, please. So what did we train the nurses on? So we trained them to perform a short geriatric assessment during a semi-structured interview, and they screened on the 4 domains of a geriatric assessment, so somatic, social, psychological, and functional domains, and combined them with tests. For example, the timed up and go. I think you know them. It's a small test that patients need to stand up from a chair and walk 3 meters, turn and walk back, and sit down, and you can do that then 2 or 3 times, and the time they take is has a predictive value of postoperative complications in major abdominal surgery. So we train to perform those tests by nurses, and we also just not the testing, but also to look at aspects like walking, turning around, how's the patient standing up, is the patient still remembering what to do, for example. So all those aspects we also take into account. Test on cognitive. We have also a short screening test, and that's a 6-item cognitive impairment test. We screen for malnutrition and of whether patients are at risk for having a delirium after surgery. for example, and of course we're screening patients on frailty with the Groningen frailty indicator. So we've trained the nurses on doing that, but we also trained the nurses in performing tests, but also in asking the right things. And I think just keep asking about what it is specific, because otherwise it's just a test, and often patients give answers that are satisfying of that for us, but we want to know exactly what it is and how it is. So we've trained also in communications the nurses, and we've trained it also with a training actor. Yeah, I must say an actor of a patient. So that was very interesting to see how they respond to that. And one of the other aspects besides the short geriatric assessment was also the patient's goals and preferences. Suzanne?
Shall I take over?
Yeah.
Yeah, well, we also wanted to assess patient goals and preferences because it's an important step in shared decision making, of course, to know what's of value to the patient. And also after the whole treatment period, what does a patient find important? And these are questions. I really like this image from the YAMA. Questions that patients ask, of course, that are maybe even more important than what the actual treatment entails, but what does it mean, and how will you function afterwards, physically and cognitively. But we were looking for a way to assess these goals and preferences, and we decided to use the outcome prioritization tool. This is an instrument. I have it here too, with 4 visual analog scales on 4 universal health outcomes, and this is based on work of Terry Fried, and our general practitioners made it into a physical instrument where you can move slide slide up to how important you find a certain goal. So the 4 health outcomes assessed are extending life, so live as long as possible, maintaining independence, reducing pain, or reducing other symptoms. And patients can say what they find important for that goal. And we asked the patients to, I always ask them, what is the most important health outcome? Because the idea behind the outcome prioritization tool is that, especially in intensive treatments, there's often a trade-off at hand. So if you have an intensive treatment, cancer treatment, where the goal is often extending life, then especially when you're frail, it can have an effect on your independence. And we know that older patients often find independence more important than or quality of life more important than extending life. So what we do is we ask them to rate the 4 goals, but also put them in order of importance. And what I like about this tool is that it does something to the mindset of the patient, and often also the family member that's there with the patient. So they realize that there is a trade-off at hand, and it's also a starting point of a conversation. So the numbers, they put the slides on, that's interesting, of course, but the most interesting is the conversation that you have based on these numbers. Because if someone would fill in the up, like on this example where maintaining independence is scored the highest, prioritize the highest, then the question would also be, what does maintaining independence mean to you? And for some, we've seen patients that said, well, it's so important for me that I can still ride my bicycle, because we're in the Netherlands, of course, a lot of bicycle riding. Or it's very important for me that I can still work my garden. So we try to explore what they mean with these goals. And it also has an effect on, sometimes people know this right away. They've thought about this before, but often they haven't. And then sometimes you see a conversation starting also between their family member or whoever is there with them, that continues on when they leave and go home, and they think about it and take this information with them when they go visit the doctor the next time. But of course, this is only, there's several ways of asking about goals, but this is the way we decided on, and we also taught the nurses to use this instrument in the assessment that they perform at the outpatient clinic, the surgical outpatient clinic. And like Hanneke said, the most important thing we thought was that that there is a conversation. So the geriatric assessment and the assessment of goals and preferences is not just a long list of instruments, but it's set up as an interview, a conversation where you sit down and you have the time to talk about what's important. Because often that time is lacking when they see the surgeon, who often has a long checklist of all these things that need to be discussed as well, concerning the treatment, for instance, or all the tests that need to be done. So this is, I think, a very important aspect. And like Hanneke said, I think it has an extra value that you have this in a conversation, because sometimes patients would answer differently on a questionnaire than they would when they're facing, when they're sitting opposite a nurse who listens to them. And I wanted to show you this image because we made a choice here how to incorporate the geriatric assessment in our care trajectory, because there's of course different possibilities. You could say all patients of 70 years and older, we all refer them to a geriatrician. And of course, that would mean a lot of work for us, but we're also limited in numbers. But also in our clinic, when patients are referred to, I'm a geriatrician, so when patients are referred to me, then we do a very extensive comprehensive geriatric assessment, which takes up about 2 hours. And I think that's really can be very valuable for patients who need it, but it can also be a burden for patients who are not that frail. And in a period where they have a lot of tests and visits because of their oncological workup. So we decided not to refer all the patients to us. We also decided on the right-hand side, I think what you see often too is like a two-step screening where you perform a geriatric screening by a short instrument like a G8, which is used a lot. And I put a GFI, the Groningen Frailty Indicator, because it's from Groningen, in there as well. But there's many of those, of course. And then you refer the patients who are frail based on these instruments to a geriatrician, for instance. But we know that if you perform these tests, it's about 50% of all the patients have to be referred. So still a lot. So we decided to go the middle road here and perform a geriatric assessment on all patients of 70 years and older, nurse-led and performed by the surgical oncology nurses. So not a geriatric nurse. So we embedded it in the department, the surgical department in this case. And well, the content we just talked about, the geriatric assessments, assessment of goals and preferences, and nurses bring this into the MDT meetings, where all the oncological specialists and geriatricians are present, and together we weigh this patient-specific information next to all the disease-specific information. And if necessary, patients are still referred to our department if we think it's necessary to perform a more extensive geriatric assessment. And well, the conclusion based on this multidisciplinary team meeting can of course be that the patient is fit enough for the treatment that is proposed and might need some optimization or not, or that the patient is too frail, or the treatment is not in line with the preferences of the patients, and the treatment is adjusted or maybe even towards a palliative treatment. So in this oncogeriatric MDT, I'll show you how we incorporated it in the whole care trajectory. But in this oncogeriatric MDT, we perform a stepwise approach to treatment decision making by asking the following questions. So we want to know, how strong is the indication for the treatment recommended? And these were patients that were already discussed in the tumor board. So there was a recommended treatment, but you could also say, how strong is the indication for the treatment according to current guidelines? So does the patient have complaints of the tumor, for instance? And we want to know, what's the time frame we're talking about? What's the life expectancy, estimated life expectancy of this patient without the cancer? So I'll show later how we look at that. But what time does this patient have, and what is the estimated life expectancy without treatment? So with the disease but without treatment. What is the expected burden if the disease is left untreated? Does the treatment add to the life expectancy? Does the patient have physical complaints that are likely to be resolved after treatment? What is the burden of the treatment itself, like hospital admissions, visits, complication risks? Are there alternatives? And what are the goals, preference, and expectations of the patient, and how do they influence the proposed treatment? And how does the treatment influence these goals? So these are the things we discuss in our multidisciplinary meeting. And life expectancy, there's multiple ways, of course, to look at life expectancy, but it's this is an image from the JAMA on the left, where you see that there is a big difference in life expectancy at a certain age. The top one, the top table are women, and the low one are men. Men, of course, have a little bit shorter life expectancy. But if you look at a woman of 80, then the median life expectancy is about 9 years. It's even a little longer now in the Netherlands, at least. It's about 10 years, I think, for a woman of 80 years. But if this woman has a lot of comorbidities or is frail, then it might be half of that almost. And if someone is really fit, it might be more. So we're interested in what's the time perspective, and how does this relate to the time to benefit of the treatment that we're proposing. What we often do is we look at these sort of tables, but for the Netherlands, and we see what's the median life expectancy, and we look at the comorbidities. Is someone smoking? How vulnerable is someone? And make an estimation of the remaining life expectancy without the disease. You can also use prognostic indices like on e-prognosis, for instance, where there's several of these indices you can, or models you can use to get an idea of the remaining life expectancy. which often, by the way, is longer than we think. So I want to show you a little bit of the research we performed around this topic. And this first slide is about the current tumor boards or MDTs. So before we introduced the oncogeriatric MDT, and we performed observations of tumor MDTs, and this was done with an observation, a scoring list developed by LAMP, where you can give a score of 1, 3, or 5, a Likert scale based on the quality of information discussed in or brought into the discussion. And what we found is that, of course, case history and radiological information, pathology, also comorbidities is fair information, although for comorbidities, I think it's also low. So the dark is good quality, and the lighter blue is average quality, and light blue is poor quality. And we compared this for older and younger patients. But most noticeable, I think, is that psychosocial information and information about patient views is really limited, and the input of nurses, information by nurses, was, well, almost none. So, well, that was something to be improved, we thought.
That's what we also see in much literature about oncogeriatric patients and MDTs, and the role of nurses in that is that it's very limited, and often nurses are afraid to speak up their concerns and their information, and to share their information about the patients. So I think that is it's quite similar here in the Netherlands.
Yeah, and also patient-specific information. There's been other studies looking at MDT meetings, oncological MDT meetings, and that found similar results. So what we did in the beginning with our oncogeriatric MDT, so this is the old situation, like Hanneke showed also, that mostly disease-specific information and age, comorbidity, and tumor-specific information were discussed, and the treatment advice was given by the tumor MDT. And what we did at the start, when we started this new care trajectory, we still had the tumor board weighing the same information and giving an advice. And after that, we discussed patients in the new oncogeriatric MDT. So as a separate MDT meeting, where we incorporated the nurses' information, and we looked at what this did on the treatment advice. So was the treatment advice modified compared to the tumor board, or was it similar? And what we found in almost 200 patients is that in 27% of these patients, we reached a different treatment advice compared to the tumor board. So about a quarter of patients, which is also in line with previous studies and a systematic review. But I think it's quite a high number, that 1 in 4 patients, you reach a different advice when you weigh patient-specific information gathered by nurses. We also saw that in 41%, a non-oncological advice was given, for instance, about optimization with diet, physiotherapy or feeding, or but also preventive measures to prevent the delirium, for instance. And only 13% of patients needed a referral for a comprehensive geriatric assessment. So if you compare that to a short screening test where about 50% of patients have to be seen by a geriatrician, I think personally that this number is low. And part of it was, I think, because we as geriatricians were present at the oncogeriatric MDT, and the nurses could give very good information about the patients. So how were the modifications in the quarter of patients where the treatments were modified? What we saw is that the tumor board in 85% advised curative treatment, and this reduced to 26%. And so there was much more palliative treatment or symptom relief and wait and see. So less intensive treatment modifications mostly. And as I told you, we used the outcome prioritization tool to assess the health outcome preferences of the patients. And to give a little bit idea of the patients, put here the median age, but our inclusion was 70 years and older. And frailty, if you would base it on the Groninger frailty indicator, was as expected higher in the modified group. But what we saw was that maintaining independence was the most important goal for the patients, followed by life extension. So I think it's interesting to know that maintaining independence is for many patients the most important goal, but also there's like almost 40% of patients who do find life extension still important, even though they're 70 years or older. So it's important to ask. We were also curious what this would mean for the patients, because what we found when we were implementing this, we started with a small group that extended, and a lot of surgeons in the beginning found it difficult to deviate the treatment from a curative to less intensive, because they were worried that they would harm their patients by not giving them the maximum treatment. So we were curious, and we looked at the results of the same patients and to see what happens in the first year. And we compared the patients where we said, okay, the treatment does not need to be changed, the unchanged group, to the group where the treatment was modified, as you saw, mostly less intensive. And we saw in the first year no differences in mortality. Also interesting to see, I think, is that in the first year in this patient group, the patients of 70 years and older, almost 30% died in the first year, whether or not we adjusted the treatment. What we did see is that there were less complications in the patients where we modified the treatment, but they also spent less days in hospital, so more days not in the hospital. And this was a difference of 5 days compared to 8.5 days for the unchanged treatments. So, and you could say that is a patient-relevant outcome. Hanneke.
Yeah, so the implementation was quite a challenge. We've been working like this about approximately 6 years, I guess now, but it was quite difficult because it was a change of culture. As Suzanne already mentioned, surgeons were hesitating and afraid to harm their patients by giving them different treatment. But also it was quite difficult for nurses to get started to talk with patients and to get to pinpoint the specific possible declines the patients could have after treatment, or they were at risk for. But also to talk about what is important for patients and what are their goals and what is important to keep or to maintain after treatment. And most of the nurses were afraid to ask that, to have to ask those specific information to patients. But as along the road, we saw that especially the nurses really appreciate the new care trajectory. They saw it was of additional value of their work, and they already saw a change in the response of the patients. Patients really appreciated it, and they we talked to a lot of patients, and patients all were saying, I was not only treated for my disease, and you weren't only looking at the tumor, but you were looking what it mentioned to me and what the impact of the treatment could have on my life, and what's the value of life for me. And based on that, um, uh, you adapt or customize the treatment for me, and that is very important. And so a lot of nurses, but now also the surgeons and also other disciplines are very enthusiastic about this project. However, to change something and to change a care trajectory in this way, you need a change in culture. So you need to dare, but also to have very enthusiastic people that keep telling about this process. It's really from disease driven to value driven. I don't know if many of you are familiar with the term value based healthcare, but I think this is really about value based healthcare. And one of the items we really needed, and also to implement this practice, was the support of the management, because nurses needed more time, but also we organized a separate MDT for quite a long time, and we're still doing that for a group of patients. So we needed support from the management, but also IT support is very important for registering all those outcomes from patient screenings. It's very helpful if the IT is on board, and that's one of the lessons we've learned to to have good IT support, but also to have a good financial support, because healthcare is very much under pressure for the finance part. And so this was also for the change of the care trajectory. And I think one of the biggest challenges was also, as Suzanne told us, we were doing less. So we were advising surgeons to not operate instead of operating. And of course, they were trained for many years to perform a surgical skill. And now we were saying, perhaps you're doing more harm performing that specific skill than talking to your patients. And at the moment, also the board was saying, well, if you stop operating, then we can shut down the surgical department, for example. And of course, we were saying, well, that is not the case, because we are performing surgery on patients that really are needing surgery. And that's a change in thinking, but also a change in finance and in financing our care. So that was also one of the aspects we were confronted with, and we have to take into account how to measure those finances, and what it meant to change a care trajectory, because we were only thinking at the patients and at the healthcare professionals, but we were not at the beginning not thinking about the IT and the financial part. So one of the questions we always have, especially from the policymakers, is what are the costs of this project, and can you compare healthcare costs between the new care trajectory and the regular care, and is there a change, and how can we finance the time of the nurses and the time of the geriatrician to participate in the MDT? May I have the next slide? So that's what we have done, and we've done it in a very, very small group, I know. So we looked at the data from that Suzanne just presented, and we just choose for a group of patients with colon or rectal cancer, and 66 of those patients had the new care pathway, and a control cohort from a previous study had 33 patients. Next slide, please. And we looked at the cost of each treatment. So I think this is, I'm going to try to explain because it's a bit complex. In new, you can see the cost of all the patients, and when a patient is entering the hospital, they get a diagnosis, a treatment code, and based on that code, you get from your healthcare insurance payment for us hospital. And as you can see, for one patient, there was one enormous outlier that had up to 85,000 euros of cost. And however, the mean of the costs were lower in the new care trajectory than they were in the old care trajectory group, the overall. So, and perhaps it's because we're doing less, as Suzanne showed, but it's also possible that patients and just talking and talking doesn't cost as much as a day of surgery, of course. But we're not sure, because it's possible that when patients are going home, they have more costs. So we're now talking to healthcare insurance to get more insight in the cost at home. Next slide. And the cost of annual basis per patient is only 268 euros to discuss and to change this care trajectory. So that's not much, taking into account we have patients, if they had hadn't been discussed in the new care trajectory, they had major surgery, which costed up to 18,000 euros. So yeah, then 286 for a better treatment is not a lot, I think. Next slide, please. So we're now, as I just said, we're going to trying to get more insight in the cost at home. Perhaps there are more from pharmaceutical costs. Perhaps more patients are in nursing home of getting home care. But we also learned that it's very important to have contact with healthcare insurances to get insights in those costs, but also in the policy of care and how care is being paid in a hospital. So that is, I guess, that was also one of the aspects we've learned during this whole process of changing a care trajectory, that you have to take all those stakeholders also into account. So we're still learning a lot about this whole trajectory, and how to get more insight in all the different roles, but also how to finance nurses, and especially the nurses at the outpatient clinic, because we really believe that they have a very important role in the care of older patients with cancer. Next slide. I think this is it. Yes. Are there any questions?
Thank you, Hanneke and Suzanne, for an excellent presentation. I have a few questions. And I really enjoyed that you looked at the entire trajectory. I was wondering, when you do these visits with nurses, how much time does it take? And is it before the surgeon or after the surgeon?
It's often it's after the surgeon, most of the time. And it takes about an hour to 1.5 hours for the nurses. And what we see now is, if the surgeon, based on the information they have from the GP, for example, of the referrer center, they already involving the nurse, so they ask the nurse to join them during the consult already to have an impression already. So that's what you see now, but normally it's afterwards, and it takes about 1 to 1.5 hours. Yes.
Thank you. And then my next question would be, for all the things you identify when the nurses do their assessment, how is that addressed? Because ideally, a lot of things could still be addressed before surgery if you identify malnutrition and things like that.
Yeah, well, some things we can address. However, when patients are really malnutrition, the time to surgery is too short. So that is a problem then. Before the malnutrition to stop it. So and also physiotherapies for rehabilitation. We do some of it, but most of the time patients are too frail, or there are other problems. So patients are not up for physiotherapists before surgery. So that is a problem. Yeah.
Thank you. I have many more questions, but I'll let others ask some questions as well. Any other one on the group have questions?
I jump in for a quick question. Thank you very much, Suzanne and Hanneke, for your presentation. It was really, really interesting and really hits a lot of important points. Thank you. I was just wondering, Suzanne, while you were presenting the 2 trajectories, you showed in the new trajectory that there were actually 2 MDT rounds, the original one and then the oncogeriatric one. I am just wondering if in that oncogeriatric one were the same surgical team members and oncology team members involved, and then has it continued as 2 separate rounds, or is that now integrated just in a single MDT in actual practice?
Yeah, well, thank you for that question. Your first question about, is it the same people in the 2 MDTs when we started, and the oncogeriatric MDT was after patients were discussed in the tumor board. Those were not always the same persons, but the main oncology specialists were present at the discussion. And that also has to do with, of course, a high burden on oncological specialists with MDTs, which is also a problem of having a separate MDT, but it was not feasible to incorporate it into the existing MDTs right away, because also we all had to learn from each other, which is, I think, a huge benefit of having an MDT with all these people present. Because the surgeons had to learn about geriatrics, and we had to learn about oncological treatment, and the nurses had to learn to present to patients and get a position in this MDT. So I think it had a lot of benefits to have it separate, but also some downsides, of course.
And at the beginning, we also had a lot of ethical discussions about what is the right thing to do, and can we do it? Is it are we doing any harm? Of how are you? What's your vision about taking care of patients? And what is for you the added value of certain treatments? So that was also a very important aspect in the beginning, especially. Yeah.
So, and now we've been doing this for several years, and we still have a separate oncogeriatric MDT, but the order is now mostly reversed. So patients are often discussed first in the oncogeriatric MDT and then in the tumor board. And we would like to see if it's possible to combine those, of course. But the difficulty is when we did the observation of the tumor boards, we found that the discussion time for each patient is really short, between like 4 minutes. So what do you do with these complex patients and the information, input of information? So that's a challenge. And it also, I think, has to do with, if you look at tumor boards, there's a lot of functions that those boards have. It's not only the discussion of patients and treatments, but it's also making sure that radiology results are being seen by everyone, and pathology. And so I think that something needs to be changed in those tumor boards in order to make them more patient-centered. Because I do think you could almost say that it's almost not ethical to discuss a patient without having the context and the preferences, at least in my point of view. And the way to make sure that you do this for every patient, of course, is to incorporate it in the MDTs. But that's still a challenge, and we're gonna see if we can manage with some of our MDTs and see how that works. But that's really the next step.
Anyone else? A last question, because I see we're getting at the end of our hour. Then I have a question. How many nurses do you have trained in doing this?
I need to count it. We've trained all the nurse at surgical, the outpatient clinic that is now up to, I think, 15. And we've trained at the head neck cancer, that are 4 nurses, and also the gynecology nurses, that are 3. So more and more departments are, and more nurses especially, are coming to us and asking to train. And so that's in our hospital now. Yes.
Well, that's great that you have so much interest from other nurses to learn these skills and be involved. And then as we are out of time, I would like to thank both Suzanne and Hanneke for an excellent presentation. And I would like to thank everyone for joining. And I see there's questions about the slides. We'll post the webinar on our SIOG Nursing Allied Health website for everyone to see. And then we'll have a next webinar next month. I hope I'm not remembering incorrectly, but Soda, correct me if I'm wrong. It will be June 22nd, 5 p.m. United Kingdom time, on immunotherapy in older adults and managing adverse events. So we'll have that next month. So thank you again, both, for your excellent presentation, and thank you for joining, and then have a lovely evening, afternoon, or morning, wherever you are.
Okay, thank you, everyone.
Yeah, thank you for the invitation. It was nice.
Thank you.
Thank you.
Thank you
very
much.
Great presentation.
Awesome. Thank you.
Thank you so much.